My speech is about the use of acellular matrices, ADM, in breast surgery. ADM is frequently used in primary or tissue-expanded breast reconstruction, and more commonly also in revisional procedures following aesthetic breast surgery. Benefits include an improved control and support of implant position, a better implant coverage, and the suggestion of a decreased capsular contracture rate. The gold standard, what we have done before, was recruiting several kinds of sheets, like the rectus abdominal sheet, or, for example, in combination with a tummy tuck using deepitalized skin. And more recently, we are using ADM. So there are several kinds of techniques how we can use a matrix. The most common technique is the reconstructive technique, where the matrix is placed between the chest wall and the pectoralis muscle. It is useful in difficult and recurrent capsular contracture and rippling and implant bottoming out. You have to place the matrix smooth without major faults or wrinkles. And it is essential to have good contact with the breast skin flap to ensure the proper technical integration. Therefore, we place drains, one between the implant and the matrix, and another one between the matrix and the breast skin flap. These drains are left in place until the output is less than 30 mm over a 24-hour period. Clinically, when seroma develops, it must be addressed immediately, for example, with the placement of an additional drain. Here we have a short video of the macroscopic signs of incorporated matrix after 6 months. As you can see, we have functional bleedings at the matrix surface. We have a strong adherence to the breast tissue, and we have no macroscopic signs or evidence of capsular contracture. And as we can see, we have a very nice shape and envelope for the implant pocket.
Dear Chairman, dear colleagues, I want to talk about breast surgery with an autoprosthesis, especially the use of autoprosthesis in ptotic breasts. What is ptosis? Ptosis is mainly classified according to the degree of parenchyma ptosis and the position of the nipple areolar complex. The definition of the degree of parenchyma ptosis is defined by the contact between the breast and chest skin in upright position, while the neck ptosis is indicated by its relationship with the inframammary fold. There are several surgical options. You can treat the ptotic breast with only with implants, you can use mastopexy or a combination of both, but you have also the opportunity to use the autoprosthesis for mastopexy. The meaning of autoprosthesis is that the basis for this technique is the use of breast tissue as a biological implant for increasing breast projection. The first description of first use of autoprosthesis is described by Ribeiro and Becker in 1973 in Rio de Janeiro. Their techniques are a combination of superior and inferior flap approaches. The nipple area complex is based on a superior pedicle, and the inferior dermoglandal flap is tailored as a small autogenous implant, which is tailored and anchored to the breast pectoralis muscle. Take-home messages are: the parenchymal flaps demonstrate ease of pedicle shaping and breast remodeling in patients undergoing mastopexy. The autoprosthesis technique is safe, versatile, and reproducible. For further volume increase, autoprosthesis technique can be combined with.
Ladies and gentlemen, first of all, thank you very much that we are invited here in your wonderful country, and have had some wonderful days yesterday and the day before yesterday, and now we have to concentrate a little bit more on our scientific themes and topics. And my part is this talk to tell something about reconstruction possibilities of the thoracic wall and the pelvis. If you look at these pictures, we have 2 points. One point is there are 150 years between, and the second point is that we have much more time today than in earlier times for reconstruction, for doing two-step procedures, or for doing microsurgery also.
Thank you very much. I really like to use a trick. I offer to postpone my talk to next year to get the chance to come back to Istanbul. next year, but it didn't work. So now I have to go back and submit a new talk for next year. Thank you for having me here. It's a wonderful city, and I always like to be back here. So after having seen so many really great cases, I'm going to show you, sorry my words, shitty cases. Why is that? Because nowadays breast augmentation is one of the most frequent operations. It even bypassed lipoplasty, as you've seen here by the statistics of the American societies, in a comparison from 1997 to 2012. If you punch in Germany plastic surgeon, you're going to find already 1,144 hits in plastic surgery. If you punch it into Google, you get more than 136 million hits if you punch in plastic surgery. So it's very easy. We have an increased demand in plastic surgery. We have more surgeons. We have a more intense internet marketing, which all comes down. More surgeries means more complications.
Like filling of the breast, and I was asked about safety about it in lipofilling. And the thing is, when we talk about safety, we think two things. One is reliability, and the other is safety. Why is that so? Yoshimoto had a nice investigation on which part of the family.
Surgical breast reconstruction, and I'm honored to be invited to speak here on behalf of the German-Turkish Association of Plastic Surgeons, and I think it's a very nice concept to bring us all nearer together. Actually, breast surgery is one of the most important fields, I guess, in plastic surgery, because the female breast is one of the originally signs of aesthetics and of beauty. So we have to be responsible for taking care of these patients.